is Dr. Rob Beatty. I work at Northwestern Medical Center, and I specialize in shoulders, knees, and hips. I'd like to give you some education about total shoulder replacement. You've been diagnosed with advanced arthritis of your shoulder, and this is typically due to osteoarthritis, which is more of a wear and tear form of arthritis, but there are a variety of potential causes, such as rheumatoid arthritis, post-traumatic arthritis, lupus, gout, pseudo-gout, and others such as avascular necrosis, which can cause arthritis. Conservative treatment usually includes activity modification, physical therapy, nutritional supplements, medication, and injections. The shoulder joint with advanced arthritis deteriorates to a rough bone-on-bone, painful surface. And when we've exhausted all the available conservative options for treatment, we consider total shoulder replacement. Shoulder replacement involves removing the humeral head and replacing it with an artificial metal humeral head, along with resurfacing of the glenoid, which is the small, shallow socket of the shoulder blade. So instead of bone-on-bone, it is replaced with a smooth metal-on-plastic bearing surface, and this provides for good pain relief. Total shoulder replacement is more reliable for pain relief than it is for range of motion, strength, and function. The goal is a pain-free shoulder with a reasonable function and a reasonable range of motion and strength. For success, it's important to have an intact or at least a reparable rotator cuff. The history, physical exam, and x-rays help to make this determination. However, it may be necessary to add an MRI to more accurately assess the status of the rotator cuff. In the setting of rotator cuff deficiency, it's more appropriate to consider a reverse shoulder replacement, which is a topic that I'll discuss in a separate presentation. In preparation for your total shoulder replacement, we may need to obtain a CT scan with 3D surface reconstruction, which can then be used to plan your surgical procedure. 2 weeks prior to your surgery, I'd like you to discontinue anything that might cause increased bleeding. This would include aspirin, Advil, which is the same as ibuprofen or Motrin, Aleve, which is the same as naproxen or naproxen, or any of the other non-steroidal anti-inflammatory medications. So it also avoid the use of fish oil or omega-3 and any other supplements, some of which may cause increased bleeding. So 2 weeks prior to surgery, you'll discontinue these potential sources for bleeding. If you happen to be on warfarin or Xarelto or Eliquis, which are some of the anticoagulants, then we'll make special arrangements. You will also need a preoperative physical with your primary care provider, and this should be less than 28 days before surgery. Last month's physical isn't acceptable. It has to be current. So ideally, 3 to 4 weeks before surgery, you would be able to have your physical, and then there's time to do any additional testing that might be required. Preoperative blood work, urinalysis, and EKG will be prepared or obtained, and you'll have a meeting at Surgical Services for preoperative assessment and for some preoperative education. You'll be assigned a preoperative nurse navigator, and you'll be provided with a binder of information on total shoulder replacement. We encourage you as well to attend a preoperative educational class. And we feel this is important, that you be well educated on the entire process, and then you'll know what to expect. This can help to allay any anxiety because we tend to be more afraid of the unknown than the known. It also helps to identify and predict individualized needs that we can prepare for, and that way you can be better prepared for your surgical procedure. When you come in for surgery, you'll be greeted by nursing staff. You'll have the opportunity to meet with anesthesia, and I will be there to greet you as well prior to surgery. In the event that there are any residual unanswered questions, this will be an opportunity to ensure that you have full understanding. The chart is then reviewed, the consent is reviewed, and I sign the surgical site. The nursing staff will prepare you for surgery. An IV will be started. you'll be given a preoperative cocktail of medication to try and create a smooth process for you. The anesthesiologist will provide some intravenous sedation and will then perform a nerve block. This is called an interscalene brachial plexus block. It blocks the nerves to the upper extremity so that when you wake up from surgery, the shoulder and upper extremity will be numb. And over the subsequent 12 to 24 hours postoperatively, as the nerve block wears off, you'll be provided with medication to help control pain. You'll be educated on the use of your medication as well. After the nerve block is performed, you'll be brought to the operating room where you'll be given a general anesthetic. You will be carefully positioned on a specialized shoulder table, which allows you to be in the beach chair position. This provides for easier access to the shoulder. The procedure is performed through a 4 to 6 inch incision obliquely down the front of the shoulder, and we expose between the large deltoid muscle and the pectoralis major muscle of the chest wall. This allows us to spread in between the muscles without cutting them. The cephalic vein is protected and retracted, and the one muscle that we do have to cut through is called the subscapularis. This is a tendon that attaches to the front of the humerus. It's detached, reflected, and then we retract it out of the way in order to gain access to the shoulder joint. The nerves and vessels are also carefully retracted and protected throughout the case. The humeral head is then exposed, and the humeral head is removed, and this allows exposure of the glenoid. The glenoid is the socket on the shoulder blade, and we prepare the surface of the glenoid, and then a glenoid component is placed and secured to the bone. The humerus is then prepared, and the artificial humeral head component is secured in place. The subscapularis tendon is then reattached to the bone, and the available range of motion is assessed because this will help determine the range of motion that we allow during postoperative rehabilitation. Then the interval between the deltoid muscle and the pectoralis major muscle is loosely closed. The layers are closed with an absorbable suture including the subcutaneous tissue and skin, and the skin is then sealed with Dermabond, which is a skin glue, as well as a specialized dressing called Aquacel AG Duoderm. The AG is silver, which has antibacterial properties, and this helps to decrease your risk for infection. You will then be placed in a DonJoy UltraSling. This will be removable for gentle range of motion exercises. You will work on elbow, forearm, wrist, and hand range of motion, as well as gentle pendular exercises for your shoulder. But you'll avoid external rotation beyond a determined limit, 20 degrees, 30 degrees, 40 degrees, whatever it is, based on the intraoperative assessment of the available range of motion after repairing the subscapularis. You will also have a cryocuff, which is a cooling device that's very helpful for pain and swelling control. This circulates cold water through the cuff and helps cool the tissue. This will be used continuously for the first week and then on a gradually decreasing basis as pain and swelling improve. People do derive benefit from the cryocuff even out to 2 or 3 months postoperatively. You will receive antibiotics preoperatively to try and minimize the risk for infection. And then again in recovery, you'll receive additional antibiotic and you'll have a postoperative x-ray. Once finished in recovery, you'll be moved over to the patient care unit where you will be seen by physical therapy. You may be ready for discharge later the same day. Discharge is not based on time, but is based on criteria. You may be discharged home once you are able to be independent, getting in and out of bed, walking in the hall, provided you're eating, drinking, and voiding. If you have good pain control with medication by mouth and you're not nauseated and feeling well, you'll be ready for discharge home on the day of surgery. Some patients do stay until the following day if necessary to achieve the safe discharge goals. Outpatient physical therapy will be arranged. The goals of PT include initial pain and swelling control, then restoration of range of motion, and ultimately regaining strength and function. This will be on a gradually decreasing basis over the first few weeks post-op. Physical therapy is individualized to the patient's needs. The goal will be to regain range of motion of the elbow, forearm, wrist, and hand first, and then work on physical therapy for gentle shoulder range of motion exercise, again, avoiding that external rotation in order to decrease stress on that subscapularis repair. We will start strengthening the subscapularis at about 3 months post-operatively. Although the main physical therapy is over the first 3 months, there can be improvement out to a year post-operatively. Now, whenever we embark upon surgery, there is the potential for complications. And I would like to go over some of the potential risks and complications of total shoulder replacement. First, anytime you have surgery, there is the potential for infection. The risk in total shoulder replacement is about 1%. We make every effort to avoid this serious complication. The scar is this oblique scar down the front. As I mentioned, it's about 4 to 6 inches in length. And initially the scar will be reddened in almost a purplish color, and eventually it will turn pale. The scar can vary from a thin line to a widened and somewhat even raised scar called keloid. Wound healing typically takes about 10 days. The skin heals quite quickly, about 10% a day. And anything beyond 2 weeks would be considered a delay in wound healing, and that occurs in about 3%. There's always the potential for injury to nerve or vessel. The incidence of nerve injury is low, it's about 1%. The ones at potential risk, there's the axillary nerve, the muscocutaneous nerve, and the suprascapular nerve. And nerve injury would result in numbness and weakness, but fortunately it's rare. Bleeding and bruising always occur, and most of the time this is less than a unit of blood. The likelihood of transfusion is less than 1 in 4. DVT, or deep vein thrombosis, is a clot in a deep vein of the extremity. This occurs much more commonly in lower extremity surgery. In fact, it's about 100 times more common in the lower extremity compared to the upper extremity. CRPS is chronic regional pain syndrome. This is a rare condition characterized by an exaggerated pain response, which is out of proportion to what we normally see after surgery. Everyone has postoperative pain, swelling, stiffness, some decrease in their range of motion, strength, and function during the early phase. But with CRPS, these responses are exaggerated, they're significantly worse, and associated with a prolonged recovery time, which can negatively impact the final outcome. Fortunately, CRPS only occurs in about 1% of total shoulder replacements. Failure is also a concern, and there are a number of potential sources for failure of total shoulder replacement. This could include wear, loosening, fracture, dislocation, instability, rotator cuff dysfunction, or infection. It is hoped that the total shoulder replacement will last for 10, 15, even 20 years. If you look at a survivorship curve, there's still success of about 90% by 10 years. By 15 years, it's about 70%, and by 20 years, it's down to about 50%. In other words, there's a gradual decrease in success rate, or increase in failure rate, if you like, over time. Failure of a total shoulder replacement can lead to recurrent symptoms that may necessitate further surgery. If a total shoulder replacement fails and symptoms are severe enough, it could be necessary to consider revision total shoulder replacement. This is just an overview of total shoulder replacement. Hopefully it helps you to better understand your surgery, and no doubt you may have additional questions as a result of this discussion, and I'd be happy to answer them for you. Thank you.